My name is Hannah Cockrell, and I'm one of the fellows with the Division of General and Thoracic Surgery at Seattle Children's Hospital. I've been asked to give a brief talk on measuring disparities. Maybe. There we go. Okay. Most public health monitoring systems do not employ a metric that describes societal distributions of privilege and deprivation. Instead, health data has historically been presented in relation to socioeconomic characteristics measured at the individual or household level. Nevertheless, neighborhood-level socioeconomic disadvantage has been shown to have wide-ranging impacts on individual health outcomes. Living in a disadvantaged neighborhood has been linked to higher rates of diabetes, cardiovascular disease, emergency surgery, and earlier death. Multiple measures of neighborhood disadvantage are available to researchers. However, to date, research has not codified a standard set of variables that should be included in these indices. I will briefly describe 4 of the indices that I have seen most often used in recent surgical outcomes research. The first of these indices is the Index of Concentration of Extremes. ICE was designed by social scientists to measure spatial polarization by quantifying extremes of deprived and privileged social groups. It is calculated based on the formula shown on the slide, where A is the number of affluent persons above the 80th income percentile, P is the number of poor persons below the 20th income percentile, and T is the total population with a known income. A value of -1 means that 100% of the population is concentrated in the most deprived group, where a value of 1 means that 100% of the population is concentrated in the most privileged group. These calculations can be performed on the basis of zip code or U.S. Census tract. The Distressed Communities Index was developed by the Economic Innovation Group. It uses data from the U.S. Census Bureau's Business Patterns and the American Community Survey to calculate economic well-being based on zip code level for those zip codes with at least 500 residents. The index is composed of 7 metrics shown on the slide. Measures for each zip code are described in 5 tiers ranging from prosperous to distressed. An interactive map on the Economic Innovation Group website allows researchers to search individual zip codes. Data for the city of San Diego is shown on the slide. To access the full index data set, however, researchers must obtain a license to download the Excel workbook. The Social Vulnerability Index was developed by the Centers for Disease Control and Prevention and the Agency for Toxic Substances and Disease Registry. It was designed to help emergency response planners and public health officials identify, map, and allocate resources for vulnerable communities during public health emergencies. The index includes data from the U.S. Census and American Community Survey on 16 measures of vulnerability. These measures are grouped into 4 different domains: socioeconomic status, household composition, minority status, and housing and transportation. Each census tract receives a separate ranking for each of the 4 domains, as well as an overall ranking. The SBI can be accessed through the CDC ATSDR website. Databases are able to be downloaded both in MDB format for our GIS software as well as CSV for Excel. Lastly, Area Deprivation Index was originally created by the U.S. Health Resources and Services Administration. It is composed of 17 education, employment, housing quality, and poverty measures derived from the long-form census and updated every 5 years with the American Community Survey data. Each census block group is assigned both a state decile and a national percentile. An ADI rank of 1 represents the lowest level of disadvantage, whereas an ADI score of 10 or 100 for state and national ranks respectively represent the highest level of disadvantage. The ADI can be accessed through the University of Wisconsin Neighborhood Atlas. Researchers have the option of downloading data linked to 12-digit Federal Information Processing System codes or a 9-digit zip code. Download files are in CSV format for Excel. To conclude, ADI may be used as an alternative to SBI as a proxy for social determinants of health and health equity and outcomes research. Unlike SBI, ADI does not include race or ethnicity, which allows researchers to separate socioeconomic disadvantage from racial or ethnic minority status. ADI data is available at the U.S. Census block group level, whereas SBI is available at the census tract level. and consequently, ADI may provide more granular data and may be better used to target specific neighborhoods. Thank you.